Okay, good afternoon, morning, evening, whenever you may be watching this. So first off, welcome everyone to the first of our Panopto uh, asynchronous lectures. I apologize that this is what needs to be done, but obviously with the current health situation, this is what we are going to. So for today, I am going to be introducing neoplasias and tumorous diseases and kind of what we're looking for in relation to the changes that we can see on X-ray. There's not going to be any specific diagnoses today, but this is probably the most important PowerPoint for this second half because it really helps us to kind of solidify what we're looking at and the idea of, is this something that we need to be concerned about right now? Is this something we need to be concerned about in the near future? Or is this something that doesn't really matter and we can just kind of see it, recognize it, and then move on from it without having to explore other treatment options? So let us continue on. So again, it's we're trying to gain an understanding of the information needed both clinically and imaging wise to create a list of diagnoses or a differential diagnosis list of what could be possible entities, diseases, conditions that could result from both the clinical findings as well as the imaging findings. So when we're looking clinically, it is very important to know age, gender. This should not be gender. This should be biologic sex instead, because gender, the social construct that may be gender, really doesn't have an effect. Mm, has less an effect than the biologic sex of a patient, because obviously, if we have a male, males can get prostate cancer. If we have a female, well, females cannot get prostate cancer, right? Because they don't have a prostate. So that's why that should be more biologic sex and not gender. Race is important because certain individuals or certain races are more likely to get certain tumors. For instance, when we look at a Ewing sarcoma, I believe the statistic is close to 95% of individuals are white, uh, of European descent white. So it is less likely for others to get this Ewing sarcoma. And then obviously the history. The history is going to be important when we're looking at what this patient might be coming in with. I kind of glossed over age there in the beginning, but age is one of our key characteristics that's going to help us to determine a lot of our differential diagnosis as we go. Because there's a subset of tumors that like younger individuals, say under 25, and then there's a subset of individuals or a subset of tumors that like older individuals, say above 50. There's some in the middle there, but those are our two big classes of kind of our standard differential diagnoses, which we will get to. When looking at tumors, it's important to note that there's kind of two main categories we're looking at. And when I describe findings, I'm not going to use the term benign or malignant with them, but in general, this is kind of the two categories we want to group things as. The findings, I will use terms more like aggressive or non aggressive, and the aggressive forms are more likely to be the malignant ones. I'm just going to write aggro here. Don't pick up aggro. And the benign ones are more likely to be the non aggressive ones. Now, this is not always the case. There are certain times where benign ones can look very aggressive, or malignant ones can look very non aggressive. But in general, when you see aggressive features, it is more likely for it to be a benign, or excuse me, aggressive features, it is more likely for it to be a malignant tumor. When looking at these malignancies, We have primary lesions, meaning it occurs in the bone as a primary source. So the bone tissue itself, or tissue within the bone, is actually what is undergoing neoplastic change. And then that may spread to other sources. The other type, secondary or metastatic disease, much more common by the way, these are tumors that occur outside of bone tissue and then spread to the bones. Specifically, what we're looking here is we're looking at the tumors of the bones. Um, so, say, for example, a secondary lesion spreading to bone could be a lung tumor that then spreads to various aspects of the skeleton, would then be a secondary malignancy, which is also termed a metastatic disease. And again, the malignant ones themselves are much more likely to be aggressive. The benign ones are much more likely to be non-aggressive. All right, so now we're going to start getting into the behavior and kind of what these lesions look like. And these behaviors are going to go towards that differentiation or that determination of the aggressive versus the non-aggressive lesions. So we have osteolytic processes, we have osteoblastic processes, and a mixture of the two. So osteolytic is where we start to lose bone density, is lysing. It's actually breaking down the bone. Osteoblastic is where we actually start to get increased density. It's building tissue. Now, osteoblastic does not always mean we're building bony tissue, but it is something that is more dense than normal bone. So we can use the term osteoblastic to relate that. There are some subtypes with these, and I'll go into pictures, or I'll go into the specific descriptions now as we get to that. So the first one in an osteolytic that we'll talk about is a geographic pattern. And you can see here the term benign. Again, this is not always the case, but it is more common that it will be benign, less common that it will be malignant. So the geographic forms are the least aggressive. Often it will be slow growing, meaning it's had time to kind of create that nice, well-defined border. And it isn't this kind of fast-growing thing where we see this, you know, various destruction changes everywhere. This is the ones I like to refer to as a soap bubble lesion or a bubbly lytic tumor. One other important characteristic of this is it may or may not have a sclerotic border. So the border of it can be a nice dense line or dense border, or there can just be no border where we see kind of this lytic lesion and then we see normal bone around it. The two aggressive ones are moth-eaten pattern and permeative pattern. So moth-eaten, if you've ever seen a moth get into like a closet and eat clothes, you see these kind of well-defined holes. Well, I shouldn't use the term well-defined, but multiple small holes. And the overall portion has an ill-defined border. So overall, not the small holes, but when we look at this kind of holy area as a whole, lots of holes there, the border of that holy area will be kind of more faded out, and it won't be such a nice demarcation between normal bone and this kind of diseased bone. The other pattern, a permeative one, has these kind of really, really small holes that we can't see so well defined as we may expect in a moth-eaten pattern, but it just kind of looks crappy. The bone density is just very poor. This will also have a very poorly defined border. What I like to relate this one as is it's kind of this pattern where we see kind of almost the bone gets dipped into acid. It just starts eating away at it. We start to see this kind of really destructive change, poor bone density, and this loss of normal trabecular patterns. So for examples of these, we can see this one right here. This is a geographic osteolytic lesion. Here's the Yokoman row kind of diagram where we have the lesion in red and the normal bone and trabecular patterns around it. We can see a very nice border between the two, just a single kind of area where we have normal bone here and abnormal bone within a couple millimeters of each other. Similarly, in this x-ray, we can see a very nicely demarcated border between the disease, this kind of lytic area right here, and the normal tissue out here. So normal tissue up here, uh, geographic osteolytic change in this area. This would be a soap bubble type lesion or a bubbly lytic appearance, also termed geographic lytic appearance. This is going to often be the least aggressive, and I would be considering a more benign type of tumor subset that could represent this. The next one, here we have a moth-eaten pattern, and when we look at the Yokeman row depiction here, we have kind of this whole area where all this red representation is these kind of moth-eaten patterns. So we start to see kind of these areas of very small holes. And I'm just drawing a couple of them, but really you can look anywhere in this bone and you can see this kind of holy type of change where these just, small holes, some of them kind of come together to create bigger ones. And it's not just in the femur. You can also see it in the ilium. Just really kind of this crappy bone density where there's just all this small, holy type of change. And again, I can look almost anywhere and see it. It's not contained to any one specific area. So the fact that this is seen so widespread in all portions of these bones is a much more aggressive type pattern. So all of this change is occurring throughout the bone, multiple bones, very indicative of an aggressive pattern. And this moth-eaten kind of lytic change represents that. And finally, here we have a permeative pattern, and where I could, in the last image, kind of circle small holes, I really can't do that here. There's just this really poor bone density, and I'm going to highlight kind of the main areas of it. So this is the easiest portion where we can see this change, kind of in this bracket here. But there's also some change going out to this upper line that you can see I drew here. There might even be some more change above that, kind of this area, which just isn't as well seen because there's not as much tumor material there. Additionally, within this bone, the cortex and the medullary cavity being involved, we also have this change right here. So this is a kind of periosteal reaction where the periosteum is actually being lifted by some of that tumor material seen underneath it. We have kind of a layering effect. So there's a small layer right here. I'm going to go ahead and erase the ink now. But there's a small layer in this portion. And then up here. And these periosteal reactions, there's actually a couple layers here. These periosteal reactions we'll get to in a minute, so don't worry so much about those. But all this is very aggressive in nature. We have the tumor in the bone with this kind of poorly defined appearance. We have the tumor growing out of the bone, going into this periosteal change, and even into the soft tissues outside of the periosteum. So all of these features are extremely aggressive, and for permeative patterns and moth-eaten patterns, I'm thinking of a much more malignant type tumor, or potentially an infection that can represent or have these kind of features. It's just kind of recapping all three of them. So again, geographic, moth-eaten, and permeative. Now, I will say, for examination purposes, in general, I accept either moth-eaten or permeative as features of the same kind of aggressive pattern. Like I'm not going to In with a few exceptions, I'm not going to expect you to say one is a moth-eaten pattern versus a permeative pattern. There are a few exceptions, and that's really where we can see those more discrete holes versus if we can't. In general, though, I'm not going to be asking that. It will come into play with a certain differential we get to later um, when I'm asking for what is the most likely of the subset of differentials you have. And we'll touch on that when we get into the specific disease. All right. Osteoblastic change, on the other hand, we really just only use localized or diffuse. So localized or solitary lesion, where we have one spot, versus diffuse, where we have multiple spots, often in multiple bones. In general, diffuse change, multiple bones, whether it's lytic or blastic, is aggressive. So we really like this one, diffuse, as a more aggressive pattern. The localized may be aggressive, may be non-aggressive. So this one is not as specific as when we talked about the geographic to a more benign type of tumor, the geographic osteolytic. The localized form can be both benign or malignant, or could be either benign or malignant, not both. So with osteoblastic change, we're really looking at a lot more characteristics than just single versus multiple. We really want to see either well-defined or poorly defined borders for a localized one. But as soon as we're seeing multiple ones, multiple lesions, that's where you're really going to an aggressive pattern. And it doesn't matter what the borders look like. All right. So here we have two images. Here we can see in the spine image, this vertebral body has a very dense appearance when we compare it to the ones above and below. Now, don't be confused with the iliac crest coming across. Do not let that fool you into thinking that this is a similar density, similarly with all the tissues in the sacral area. Like this area is very dense as well, but there's a lot more soft tissue there. There is not soft tissue at this vertebral body, or that degree of soft tissue. There's some, of course. This is what we can term an ivory vertebra. And an ivory vertebra, while being a localized process, is more likely to be an aggressive process or malignant disease compared to a benign disease. There's not many causes for a benign ivory vertebrae. What will help with this is we'll commonly see these in older individuals. So in general, once we start seeing tumors occur in older people, we're thinking more aggressive in just as a normal kind of process. But this may also affect a lower or a younger subset. So this is something to consider. And once we get into the ivory vertebrae differential, that should make a little bit more sense. So that will be more to come. The diffuse change, on the other hand, we can look and we can see this kind of blastic process seen in almost all portions of this ilium. Maybe, yeah, all portions pretty much. When we compare the patient's right side to their left side, we can see that the tissues, or the bony aspect of the ilium, is much denser on the right than it is the left. And now we may have seen some images in the past where I showed you things in a similar manner, where like the right side was more dense than the left, but that affected all tissues equally on that side. If we look at the femur here, well, this femur has very similar density to this femur, the right versus the left. So we can't use the whole side being more dense due to some technical factor. This is truly being seen in the patient. Additionally, it's not only on that right side. We also have change, not to the same extent, but we also have change along the left ilium. So all of this area is a little bit more dense. And then right side, it's pretty much, oh, that's not what I want to do. Right side, it's pretty much all portions of this bone. I'm just going to circle the whole thing, obviously. Oh, I guess I could do this. Yeah. So that is diffuse change. We see it both on the right and the left, multiple bones. This is much more of an aggressive type pattern. All right. Mixed bone destruction. This is where we expect to see patterns of both, where there's some lytic change and some blastic change. So looking at this picture, we can see the femoral metaphysis going into the diaphysis and probably beyond a little bit more, just not to the same degree. All of this is extremely dense. It is very difficult to tell the cortex versus the medullary cavity. Remember, that's one of the things I told you to look for when we were talking about osteopetrosis. Look for corticomedullary um, indistinction. Here, we have a very similar type of change. I can't tell the difference between cortical bone and medullary bone. So there's just a lot more density there. There is osteoblastic change to that region. When we look more in the metaphysis going to the epiphysis, though, we've lost cortex from here to here. Well, cortex is bone. If we're losing bone, that is osteolytic. So we've lost that kind of bony tissue, and then additionally, we might have some osteolytic change through here as well. So this bone shows features of both osteoblastic change and osteolytic change. So it will be a mixed pattern of destruction. And this one has an aggressive nature. Again, we've lost cortex, so that's an aggressive type of change. We have this kind of poorly defined borders between disease and not disease bone, aggressive change. And then also this growth with periosteal growth, potentially going out into the soft tissues. All aggressive features that we're seeing here. What helps to say that this is also aggressive tumor, or was also an aggressive tumor, is that this is a specimen view. There's no tibia below it, so this probably got taken out of a person. Oh, segue right into that cortical change. When we are looking at the cortex, this can help us to determine more aggressive versus non-aggressive features. So if the cortex is intact, that is non-aggressive. It's a good finding. That means the tumor is either in a very early stage or it's more of a slow growing change. When we see cortical destruction, either erosions of it or penetrated, so back to this image before, we've lost the cortex. Let's erase the ink. We've lost the cortex in this region. I don't see it. There's no line here. I can see it on this side. There's a cortex right here. But I do not have that similar kind of density seen in this region. That is aggressive. So it could be either an infectious change or a malignant tumor that could be causing that aggressive reaction. And then we may also have some expanded cortex. And these can either be benign or malignant. So I'll show you examples of those, or I'll talk about those when we get to it. After changes seen in the cortex, we then look to the periosteum. So I've mentioned this a couple of times. I've talked about this periosteal reaction that we're seeing. So going back to this picture here, all of this is periosteal change. So here's the cortex, or what should be the cortex. This is that periosteal change that we're seeing. Periosteal change all throughout here. And similarly, we have the same stuff going on this side. Now this one kind of has this spiculated hair on end type of appearance. That's one of our periosteal growths. So that is this one down here, spiculated sunburst or hair on end. This is a very aggressive type of reaction. We may also have Codman's triangle. I guess I'll go from bottom to top here, but Codman's triangle as this kind of primary malignant, also aggressive reaction, so more malignant or potentially infectious. We can have a laminated, layered appearance, or we can have a single layer, which is a little misleading when I talk about laminated and single layer. What I often call this one, and what I learned it as, is a solid periosteal reaction. So instead of it being a layer, it is just growth from the cortex to the periosteum, and it's this solid piece of new bone. And this, in fact, is actually, this one right here, is actually how we uh, heal from fractures. This kind of callus formation is created by the intact layers of periosteum being around that fracture. And then obviously we can have no periosteal reaction, which could be benign or could be metastatic. The reason why metastatic disease may not result in periosteal reactions, or soft tissue masses for that matter, is because they like to maintain or be in an area with a very large amount of blood flow. So marrow has a lot of blood, or a lot of blood and nutrients in it, versus the cortex, it doesn't. So that's not to say that metastatic disease can't affect the cortex. It often does, but metastatic disease likes to live in the marrow regions more. All right, so let's look at some pictures. This will make a little bit more sense as we do it. So in this diagram here, so this is normal cortex, right? So we see cortex here versus medullary cavity. Here on the portion on this side, we have this kind of layer or growth, and this is that solid, which I like to call it, as opposed to a single layer. So this is a solid reaction when we look at this image, a solid periosteal new bone growth, which essentially looks like just a new piece of cortex, right? I mean, the density here and the density here, very similar. Now, part of that is because there's actually a tumor living in that portion, creating all this extra bone. But this is a kind of solid new piece of cortex. And that's a normal physiologic response. Once the cortex gets lifted, the body doesn't like that. So it'll like to and start to grow bone up to that kind of quote unquote gap from the cortex to the periosteum. And that is a solid periosteal reaction. The next one is laminated or onion skinned. So in this diagram here, we can see there's this multiple linear drawings, which represents the darker portions represent a piece or a layer of bone. The lighter portions represent a more lucent region where there is likely some amount of tumorous material. When we look at this individual here, we can see change all the way from the top of the image to the distal metaphysis. Now, if I zoom in, we can see this a little bit better. So we can see this kind of layered nature where we have cortex, we have a lucent layer, we have a solid layer, another thinner lucent layer, and then another solid layer. So it has this layering effect. And laminating something just means to layer it. So a laminated piece of paper is, I don't know if you guys have experience with that, but we used to get paper laminated back in the olden days when paper was used. Little joke there, sorry. So laminating something would be layering it. So if you're laminating a piece of paper, you're putting a layer of plastic on the top and a layer of plastic on the bottom to keep it kind of protected. So this laminated periosteal growth is indicative of this kind of start-stop of tumorous activity. So the tumor starts to grow, it lifts the layer a little bit, and then the tumor kind of goes a little bit more dormant. It's not as active. The body has some time to put down a solid layer of periosteum, or a single layer of periosteum. And that's why I really don't like that term single layer. After that layer is put down, well, the tumor starts getting a little bit more active, pushes that layer up, and then the body has a little bit of time to create another layer of periosteal bone. Then the tumor gets more active. So we get this kind of layering effect where we have, tumor, normal, tumor, so on and so forth. We can see on the other side, there's just kind of this aggressive, not well-defined lesion. So we have a permeative osteolytic pattern seen in here. So that's that permeative osteolytic pattern. So both this permeative change as well as this laminated periosteal reaction is consistent with an aggressive lesion. And I would be thinking more malignant tumors than benign ones. The fibula also shows these changes. So here we have a single layer of lamination, which is aggressive because it's not just a solid piece of bone. We have a single layer of density and then a layer of lucency. So there is still laminated appearance. Here we can see a cut onion. So you can think of this as an onion skin appearance as well, or onion skin laminations. So all of the red onion skin layers, so to speak, laminated periosteal reaction is like ogres. It has layers. Never mind. So we can see multiple, kind of what you can relate to the bone growing, the solid portions, versus the kind of tumorous portions in the middle. I guess I shouldn't draw that big. The tumorous portions in the middle as the kind of middle portions. So these are laminated periosteal reactions. They're aggressive forms. We saw a spiculated one before, so here's another one. Can also be called hair on end. So hair on end, right? I believe these are Van de Graaff generators, if I remember correctly. This is this kind of static electricity machine where if you put your hand on it, your hair starts to stand on end. It's pretty cool. So in this image, we can see the Yoakum-Rowe diagram where we have this perpendicular lines. I should use that term. If we go back to the laminated one, this is multiple parallel linear densities versus the spiculated multiple perpendicular linear densities. So in this region, well, actually up here, we have a little bit of onion skin or laminated layering, and then out here, we have that spiculated appearance. So you can see these together as well. It's not like it's one or none. These can be both present, especially because spiculated and laminated forms are both aggressive reactions. All right. This picture does not come through very well, but there is a fine spiculated periosteal reaction there and there. It's not well seen in this kind of compressed video image, so I apologize for that. Um, don't necessarily stare at this one trying to see it. It's just it didn't come through very well. All right, another type of spiculated reaction. So instead of being straight perpendicular, you can kind of get this sunburst type appearance. It's the same idea. We're seeing these kind of linear radiating densities. I wouldn't necessarily say this is a sunburst pattern. I would still use the term spiculated. But if you guys use sunburst, that's fine. This is also an aggressive reaction. All right, one of the kind of harder ones to get a handle on that I found most people have is what's called a Codman's triangle. So this is a weird one where when we're looking at the lesion, so say we had this kind of growth in here, so here's the tumor, it starts to grow out through the cortex, so it destroys the cortex and comes out into the soft tissues. Well, as this tumor is going, it starts to pick up the periosteum. And the periosteum is this tethered thing, right? It's still tethered to the rest of the cortex peripherally and distally, or peripherally and centrally. Well, the area that gets kind of lifted that is not tumor material can grow. So this portion here, this triangle, is representing a new bone growth due to that periosteum being picked up. So in this image, we can see these triangular densities. These are the Codman's triangles. So the tumor is growing out into this region. So kind of connect those lines. So this is tumor. There's probably some amount of change in here too, but it's harder to see because of the kind of aggressive nature of this, where we don't see all of that tumorous destruction. But these triangular densities that are growing out, these are the Codman's triangles. And while they are specifically not the tumor, the fact that we can see them with this kind of lytic type destruction seen above it, that is evidence of more of an aggressive lesion. And it's specifically the portion that's growing out that's telling me it's aggressive. So the tumor portion going to the soft tissues, and not really the triangle density itself, but that triangular appearance helps me to know, okay, I have to look at the edges of this triangle. Is it just a nice solid sloping portion, or does it kind of go away as we see up here, where that periosteum, just that growth kind of stops, and then we get this more lucent change where we have that tumor going. Here we have two areas. There's a small Codman's triangle here, and then perhaps one right here, although this looks like an internal rotation, and that may just be the kind of lesser trochanter. Do I necessarily need that Codman's triangle to kind of give me that, differentiation that it's this aggressive change? No, because we can see this kind of mixed permeative lytic blastic change. So we have kind of some increased density all throughout the uh, humeral metaphysis into the diaphysis, but we've also lost cortex. Like there's no cortex from here to here. We've lost cortex here. There's lytic spots seen in these regions. So this is a very aggressive type of pattern. Again, we lost that cortex. So by definition now, the fact that the cortex is gone, I'm really concerned for this patient. This long zone or this wide lesion, I'm also concerned. That's not normal. Smaller or more benign tumors shouldn't be that big. So I'm thinking more aggressive and malignant lesions in this case. One of the other things we like to look for are the edges of the tumor. So margination or zone of transition. This is where we can say either there is a very well demarcated border, so we can see exactly where there's tumor bone and exactly where there isn't tumor bone, or we look at it and we say that, the tumor kind of is in a larger area more than we can really see as a nice, well demarcated portion. So here we have a short zone of transition. This could be termed a geographic osteolytic lesion. In fact, when you say geographic, that almost always implies a short zone of transition. So I can trace the borders of this tumor. The tumor is right here. There is no real tumor cells outside of it. It is, kind of like a well-defined geographic or geometric shape. Here's another one, a well-defined geographic osteolytic lesion, has a short zone of transition. Here's another one, geographic osteolytic lesion, short zone of transition. Wow. Okay, so it's not just the trackpad, it is also just randomly, because I'm using a mouse now, and it drew that, horizontal bar for reasons. Don't pay no mind to the man behind the curtain. But this here, this circular portion, is that geographic osteolytic lesion with a short zone of transition. When we start looking at more long zones of transition, well, if we zoom into this region, the tumor, the majority of it is right here. But there's probably some tumor change in here. Like this does not look, this more lucent portion or lytic portion does not look normal. Additionally, there's kind of these tracks going up. So this tumor I can tell is mostly right here, but there's some of it here, some of it here, some of it here, and maybe even some of it coming all the way up into here. This doesn't look okay. This doesn't look okay. So this has a very long zone of transition. I can't point to exactly where all of the tumor starts or stops. The representation here, the diagram here is, well, there's most of the tumor right here, but then these hash marks start getting smaller and smaller as we go out towards the edge because we're not seeing as much change. So if we reach way, 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 way back into our memory banks and we remember when I talked about x-rays, for bone density change to be visible on x-rays, or for it to show up on an image, it needs to have 30 to 50% bone density change. So maybe this is like 80% up here. Maybe this is 70%. Maybe this is 60%. Maybe I shouldn't have used those numbers. Maybe this is, let me go back. Maybe this is 50%. Maybe this is 40%. Maybe this is 30. And then maybe we're at 25. Maybe we've got some 20. Maybe we've got some 10. So this kind of zone of transition where we see it, the most of it in one spot, but we also see a lesser change elsewhere, could be more of a product of the fact that X-ray just can't pick up subtle changes in bone density. So just be aware of that and look at like the whole bone and try to see if you can tell exactly where it starts and stops. Here's another long zone of transition. Well, there's a lot of tumor in here, but there's some here, there's some here, there's some down here, and maybe a little bit into here, right? So there's a lot of it here, and then it just kind of fades out. So it has a gradient. This is a long zone of transition. This is an aggressive reaction. Long zone of transition. Now, sometimes these long zones might look like they have a well-defined border. So right here, it looks like I can draw it. But so this is kind of the main area, but there's also main area up here. And there's also some change through here. So this kind of whole area, this has a long zone of transition. There's healthy bone maybe over here. Maybe there's some change seen here and here. So it's not easy to explicitly define where these borders are. Additionally, I don't know if anyone saw it, there's another spot in the ribs. So there's change both in the humerus and the ribs. So whether we see this zone of transition or not, we have multiple bones or multiple areas affected, and that is more likely to be something aggressive or something malignant. All right. So a short zone of transition versus a long zone of transition. Okay. Lesion matrix. So far we've talked about lytic change versus blastic change, and this ties into that when we talk about what is inside that lesion. So there's a couple things that are often more lytic, and there's a couple things that are often more blastic or denser. So these first three commonly will be more lytic. Now there's a little bit of star there when we talk about cartilage, because cartilage, well, I should really just, there we go. Because when we talk about cartilage, cartilage likes to calcify. So cartilaginous lesions can have a little bit of kind of blastic type change. This one will be more, I guess I should do this, blastic, osseous change. Obviously, we would expect osseous lesions to be more dense. And then finally, when we talk about fibrous, fibrous is somewhere in between lytic and blastic. It will often be less dense than cortex, but more dense than medullary cavity. So here, a couple examples of fatty matrices, both in soft tissue. So here's a very large lipoma. We can see normal kind of muscle out here versus a lipoma right here. And it has a well-defined border. And now I will not test you specifically on soft tissue lipomas. Like this is not testable material. These two are though, very much so. So this is a lytic lesion seen in the calcaneus. So here we have an x-ray, a lateral view of the ankle. Here we have a CT scan, which is showing us those similar changes. Now, you might be saying, Dr. Cote, you said this was lytic. When I look here, there's a spot inside of it that's blastic. All right. Well, lipomas like to be difficult. Really only in this area. You're not going to see this kind of change elsewhere. So, hint, hint, that makes it a really easy test question. Lipomas, when we see them in the calcaneus, there's a couple differentials, and we'll talk about that as we go on. But when we see them in the calcaneus, they like to affect this region. And lipomas, intraosseous lipomas, like to go through stages. Stage 1 is where it's just a fatty lesion. Stage 2 is where the middle portion starts to undergo necrosis because it cannot get as much nutrients. And stage 3 is where it starts to ossify. So that necrotic portion will ossify. So we're looking at a quote unquote or a stage 3 lipoma where we have this osseous change in the center of it, but around it is still this lytic fatty matrix. Cartilaginous matrices. There's 3 different types, and these are confusing to get through your mind. So ask me questions about this in lab, please. I'll do my best to kind of make it more clear. Um, all 3 of these are different appearances of that cartilaginous matrix. They can be present all together in a lesion. There can be like one of them, it can be 2 of them, or it can be all 3. So there is a stippled or punctate, meaning many, many dot-like appearances, right? So that's kind of a stippled or a punctate type of cartilaginous matrix. You can have a flocculent one, which is sheep's wool-like, and I can't really draw that. I'll point it out on these images, but this is kind of sheep's wool appearance. And then there's arcs and rings. So arcs or rings, right? Now, when we look at these images, the punctate or stippled ones are best seen here. So if you look closely, there's like this dot-like appearance inside, lots of fine dots. Maybe there's a little arcs. Again, punctate, and there's also a pathologic fracture right on this edge as well. Here we have more so the flocculent. So this denser area in here, well, mixed lytic and dense areas, is that flocculent portion. But on the edges of this, we're starting to get that kind of arcs and rings. Here we have punctate or stippled, and then flocculent in here. So just to reiterate those arcs and rings, because I kind of covered them up, but here's kind of an arc. Here's an arc. There's some smaller arcs in here. Maybe there's a little ring there. Maybe there's a ring here. We have some fine peripheral calcification around it as well. This is more cartilaginous in nature. Those are kind of the arcs and rings. So those are all features that we can expect in a cartilaginous tumor. So in general, cartilaginous tumors will be lytic compared to bone, but when it calcifies, there will be this kind of blastic type change or increased density of that stippled, flocculent, or arcs and rings appearance. And then finally, osseous. This is where we went into the diffuse and focal osteoblastic. So on this right image, we have a focal osteoblastic lesion. There's a solitary focus. It's not really elsewhere. On this one, we have a diffuse change seen throughout this. Excuse me. Seen throughout this proximal femur. It is diffusely seen throughout it. It has a long zone of transition. This one is more aggressive. This one is non-aggressive. So I'm thinking more malignant tumors here and benign tumors here. All right, then we get the hardest matrix is a fibrous one. So this right side image is a normal bony tissue. This left side image is showing us that fibrous matrix, also termed a ground glass appearance. So this ground glass appearance, I always liken it to if you take a piece of glass, you grind it up, and then you try to shine a light through it, you will have this hazy appearance. It's not going to be, a nice beam of light going through it. It will diffuse throughout those pieces of glass and give you more of this kind of scattered, not nice single beam appearance. Another way of thinking of it, it's if you took the trabecular patterns and drew them with a charcoal pencil or charcoal, maybe even like a crayon. Charcoal pencil is going to be easier to relate. And then you smudge them. So instead of having those nice lines, if you smudge it, it's going to kind of become more faded or hazy. I've also heard people describe this if you take a balloon, take a nice big puff of a cigar and blow that into the balloon, well, it has this kind of smoky or hazy appearance. Now, this fibrous matrix one, all of the bones of the hands are showing it. So there is no normal area I can really point to, which is why I gave you a normal picture here. When we look at kind of the metacarpals in this region and compare it to the metacarpals here, it has this hazy, smoke-filled appearance. Additionally, the phalanges are affected as well. So this fibrous matrix is associated with fibrous tumors. Okay, next. After we've seen what the lesion does in the bone and the cortex and the periosteum, if it keeps going, it will grow into the soft tissues. Now, don't be confused by this. Soft tissue mass does not always mean it is a soft tissue tumor. For instance, a bony tumor that grows out of the bone into the soft tissues would have a bony soft tissue mass. So while that sounds kind of confusing, think of it like this. If you see the tumor growing into the soft tissues, that is a mass that has grown into the soft tissues. It is a soft tissue mass. So it's extension of these tumor cells out of the bone into the soft tissues. That mass is growing outside the bone. We often will see this with primary malignancies and infections. This is not something we expect to see with metastatic disease because, as I said before, metastatic disease likes to affect the marrow because there's a lot of blood flow and nutrients in that region. It doesn't like to go into the cortex or out of the bone as much because there's a lot less nutrients and a lot less blood there or blood flow there. So soft tissue masses are features of aggressive tumors, often a primary malignancy or an infection. So we can see this X-ray here. We have this denser region all throughout here, but it is mostly osteolytic. Why do I say it's osteolytic? Well, if we look in this region specifically, we start to see loss of normal trabecular patterns. And where did the cortex go? From here to here, there is no cortex. So there is an osteolytic destruction, and we can kind of trace this rim here, and then we lose it, right? So there is something growing from the bone out. When we use advanced imaging, the CT, well, we can see better margins of this tumor. And we can get a sense of exactly how big that tumor is and the fact that it is growing from inside the bone to outside the bone. It has created a soft tissue mass. Other features that help us better differentiate what type of tumor it is are the origin of the lesion. Like, where is it coming from? Is it coming from the medullary cavity? Is it coming from the cortex? Or much less likely, periosteum, or even outside the bone itself? So you could have bony tumors growing in an extraskeletal location. And that gets confusing. This is not something we will test on extensively. In fact, not really at all. But be aware, you can see tumors like an osteosarcoma grow de novo from, say, muscle tissue or fat tissue, like subcutaneous fat. Now, this is a rare occurrence, and that is a type of uh, dysplastic tumor where the normal cell lines turn into a completely different cell line and then start undergoing tumorous growth. So this is not something we'll see too often. In fact, I doubt boards really test on it. We're really going to focus on these two, medullary cavity and cortex. Most tumors like to grow in the medullary cavity. There's a couple that will grow from the cortex, and that really helps us to differentiate which one it may be. So when we get into specific tumors, we'll come back more to this as a feature. Here we have a medullary cavity tumor. Now, if we start looking at this and we kind of consider the other features we have seen, well, this has this increased density, but it has kind of like an intermixed lucent areas inside that increased density. So you can say there's some arcs and rings and maybe some flocculent change. Maybe there's a little ring, maybe some small arcs. You really got to kind of put on your art eyes to see this stuff. But there are some of these arcs and rings, some flocculent change, arc, ring, so on and so forth. So this tumor is growing in the medullary cavity of this humerus and has a cartilaginous matrix. So that helps to narrow down and exclude a lot of tumors. So for this one, because we see this calcified matrix, we're really thinking that this is a cartilaginous tumor. And then we can follow down what tumors we know that come from cartilage. And you'll have to wait to know that answer. So come back in a couple weeks' time and I'll tell you. But this is a medullary cavity tumor. Here's another medullary cavity tumor. This one is a much larger one. This one spans pretty much the entire distal portion of the femur. There's also some laminated periosteal reaction here. We have this Codman's type triangle. Maybe a little Codman's here too. Actually, it's kind of bigger. This portion with some periosteum growing on top of it. And then we have an area where we kind of lose the periosteum, where we have this tumorous growth, you know, all this kind of spotty change growing out into the soft tissues. So this lesion grew from the medullary cavity. Let me erase everything real quick. Grew from the medullary cavity and then started growing out of the bone. So this is a medullary-based tumor which has aggressively grown out of the bone. So we have an osteoblastic tumor originating in the medullary cavity, creating both Codman's and laminated periosteal reactions, and having a mass growing into these soft tissues. These are aggressive features. Once we lose the cortex or go through the cortex, raise the periosteum and grow into the soft tissues, those are aggressive features in this medullary-based tumor. Another example, this one, not another example of a medullary one. This one is a cortically. No, I take that back. It is not cortically. This is medullary based, but it's a term that you can also use eccentrically based. So it's medullary cavity towards the edge. Now, I initially started going towards cortex, but took it back because when we look here, we can see the cortex is this portion. The cortex is this portion. It is extremely thinned, but it is not where the tumor is growing from. The tumor is growing from the inner portion right here, the medullary cavity. Now, it's not central medullary cavity, which we've seen in the past too. It is more eccentric, or it's more peripheral. So another medullary-based tumor. This one is a geographic osteolytic lesion, which is mildly expanding the bone and causing an extreme thinning of the cortex. The other type, cortically based, is where we can see a lesion growing in that cortex, and it could either expand the cortex or potentially grow into the medullary cavity. So here, this picture is not so great. It did not translate well to this digital media, but the tumor is right here. That's the tumor. There's a little bit of less density here as compared to above and below. So right in here. And we don't see that change in the medullary cavity. Like there's no tumor in the medullary cavity. This area is all normal. Normal medullary cavity. Versus here, cortical tumor. Here's a couple better examples. So this one, we can see the cortex is coming down, and then it kind of starts to split around it. This is a cortically based tumor. This one similarly here, the cortex is coming down. Oops, cortex is coming down, and then it starts to split around it. In fact, we see a couple different areas of this because this kind of wraps around. It's not just on the edge. So these tumors are more cortically based. Now, sometimes this can be very difficult to see whether it is truly cortically or medullary based. I will tell you, whenever I give you an example, or when boards does it, they should give you at least 2 images, or only one if we can see that it's in the cortex, to better tell that this is either a cortically or medullary based tumor. And I'll show you a lot more examples of these when we're in lab to really help solidify cortical versus medullary based. Here is kind of an example of what I was talking about. So the tumor is in the tibial metadiaphyseal region. And when we look at this image, well, this looks like it's, smack dab in the middle of the medullary cavity. I can see that tumor right there. It doesn't look like it's in the cortex. I can see the cortex around it on either side. So nice cortex here, nice cortex here. Looks like a medullary-based tumor. So medullary question mark. Well, on the other image, we can see that no, it's not in the medullary cavity. If we look at the cortex, where we can see the cortex is starting to grow around this tumor. So this lesion is in the cortex, right? So it's not a medullary tumor. And this is an example why you would need to take more than one view of every body part. So here we can clearly tell it's a cortically based tumor. Here you can't. And that's because we're looking at it straight on the left image. So for exam purposes, I would either give you both images or only this image if I wanted you to say cortically based tumor. With that in mind, if you only get this image, the answer to a question of where this tumor would be based would be in the medullary cavity, because to the best of your knowledge, there is only this area affected. And that highlights the need for multiple images to be able to tell that, oh, it is in the cortex. It's not in the medullary cavity or just in the medullary cavity. Other features, this is not necessarily specific to aggressive versus non-aggressive lesions, but pathologic fractures can occur. And really, we tend to see these when greater than 50% of the diameter of the bone is involved. So if it's less than 50%, most likely that bone will be able to support the weight of the body or whatever that patient's doing in their normal daily activities. But once we start growing to that greater than 50% destruction, that's when, normal daily activities could actually result in a fracture. So we have an example here. If we look at the x-ray, if we trace the cortex down, the medial cortex, we can see that there's kind of this offset here. And if we go back around, we can see that there's an offset where the cortex goes kind of into this portion and then starts back here. Well, it's a lot easier to see on the CT where we have a clear change, right, and clear change. So there is a pathologic fracture going through a geographic osteolytic lesion. So this is most likely a benign lesion that just happened to have a pathologic fracture because the bone became weakened. Its architecture was not sturdy enough to maintain the body weight during normal activities. Similar change here, we have this cortically based lesion, geographic, osteolytic, pathologic fracture. It has involved greater than 50% of the diameter of the bone, so that's our high index of suspicion for pathofracture, which has occurred in this case. One important thing to note, when you see lesions like this, that's a pretty big lesion, right? That's involving almost 75% of that diameter. What the fact that there's a pathologic fracture, it tells me that this lesion was likely asymptomatic before it occurred. So this patient was going through their normal daily life. Maybe they had, very, very low grade pain or no pain at all, which is more likely. And as they're going through their activities, well, all of a sudden they take a step wrong and it fractures. And, well, now they have pain. So this is an important thing to note because pain is a clinical feature that helps us to tell benign, malignant, or certain tumors in those subsets. Here, the fifth metacarpal, we can see this change in here. There is a geographic osteolytic lesion. There is punctate or stippled calcification inside of it, and a pathologic fracture. So pathologic fracture. So likely this patient had no symptoms, and then they kind of banged their hand on a desk one day and they fractured it. Well, that's not normal. Well, that's because they had decreased structural integrity. This lesion involved more than 50% of that metacarpal head. All right. And those features, when you bring it all together, is really going to help us determine if it's an aggressive or non-aggressive lesion, as well as kind of point us towards one type of tumor or another in our differential. So using everything from clinical data, age, sex, history, pain status, to number of lesions, solitary, multiple, to lesion description, osteolytic, and is it geographic, moth-eaten, or permeative, or osteoblastic, and is it local or diffuse, or is it some mixture of both, a mixed pattern? Then we can mention the margination, whether it is well defined or poorly defined. Is the cortex involved? Do we see the cortex thinning? Do we see the cortex kind of gone? Do we have a fracture, pathologic fracture? We can also look at the internal portions. And again, that ties in with the lesion description. But the lesion description doesn't tell us, well, is it fatty, cartilaginous, or bony? So in that matrix portion, that's where we really start thinking, well, is it that punctate, stippled arcs and rings? Is it a kind of more solid piece consistent with bone? Is it purely lytic? Once we finish looking internally and at the cortex, we can start looking at the periosteum, see if there is a solid, laminated, or spiculated periosteal reaction. Is there any part of that lesion or mass growing into the soft tissues? And similarly, does it grow into the joint? And then finally, at times we may need further imaging like an MRI or a CT because the X-ray just is not enough to show us the lesion. So this picture here, let's go through that. Let's look at all these things. So no clinical data is supplied for this picture, but when we look at it, there is one lesion. So I'm going to circle the lesion right now. There's one lesion in this tumor or in this patient. It is a geographic osteolytic lesion. There is lytic change inside this. It has a well-defined sclerotic border. The zone of transition or the margin is short. Again, when you say geographic, that often implies short. The cortex is not involved. The cortex is intact. So when we look at the joint portion, that's okay. The matrix, there's no real matrix here. What we could say is maybe there's some remnant trabecular patterns or potential loculations created by those remnant trabeculae. Periosteal reaction. There is no periosteal reaction in this patient. And since the cortex and the periosteum is intact, well, it's very likely that there is no soft tissue involvement. And in fact, I would say in this case, there is no soft tissue / joint involvement. I don't see anything growing out of the bone. Cortex looks fine. I will almost always ask for advanced imaging. There are some, exceptions to that rule, but often the advanced imaging we want to get is an MRI with and without contrast. So that helps us to compare between the two. It really helps us to kind of tell if there's more lesions or some of the other characteristics that we may not have seen on X-ray because there just wasn't enough destruction yet. Further description of lesions. So type of destruction, that was that osteolytic versus osteoblastic. And then other things we want to talk about. So I didn't really get into this, but this is important too because certain tumors like specific areas. Locations. Is it an epiphyseal tumor? Is it a metaphyseal tumor? Is it in the diaphysis? Or some combination of those. I did talk about medullary versus cortically based. And position, again, that's that kind of central, where we see it centrally, or eccentric, we see it more peripherally. So looking at this patient here, if I tell you this patient has no pain, uh, we'll say it's painless, and they got this image for other reasons. Well, we can look at this and we can say, all right, we have a geographic osteolytic lesion with a well-defined border that is sclerotic in a cortically based lesion. So here we start talking about the location. So it's cortically based, diaphyseal lesion, well-defined border, geographic, osteolytic. The cortex is intact. Cortex is fine. There is no periosteal reaction. There is no soft tissue mass. The matrix is lytic, maybe with some remnant trabeculae and loculations. Yeah, went through it all. This is the one I showed you earlier. There was that lesion. Here's the lesion here. Perhaps it actually extends back here. It's tougher to see with both the plateaus, the medial and lateral tibial plateaus overlapping. Here we can see further imaging. So this was this patient here with further imaging. Well, we can see now, there's the lesion. There's the lesion. And this supports our kind of geographic appearance, though that's not always the case. Sometimes we can see more what looks like a well-demarcated lesion on advanced imaging could look more aggressive and longer zone of transition on X-ray. Again, that relates to the amount of bone density change. So the advanced imaging is really a secondary one after you've gotten the X-ray to kind of help determine if it's aggressive or malignant. This is an MRI, by the way. This is T1 image. This is T1 image post-contrast. So the post-contrast imaging helps us to tell where we see this kind of tumor solid portions. So all of this portion, all this stuff in here has enhanced after contrast administration. All right. And there's a number of practice cases. I will leave these for you guys to practice and go through. And when we get back, or when we talk about this stuff in lab, we will go over those as well as some other cases. And I would like to do some hot seat type of things. So be prepared to be called on and be able to describe these changes. My advice to you guys is before lab, write down all of the characteristics. So if you go to this one here, write down the characteristics because these are the questions I'll be asking. Right? So essentially, this is your hot seat for next, lab on Monday. All right. Well, I hope everyone is staying healthy and safe. Um, Obviously, if you have any questions about this, feel free to email me. I'm available to do, small group or Zoom, a small group or one-on-one sessions on Zoom outside of lab as well. We just have to schedule something. So our next meeting will be live on Zoom at either 1:30 or 3:30, whichever lab section you have. So those links should be in Canvas, but I will also be sending them out as announcements at the times or about half an hour before class would be or lab would be. So I hope everyone has a great weekend, and again, I hope everyone's staying healthy and safe. That is all for today. Goodbye.